We next go on to a topic known as dysphagia. Uh, so there is a general comment I would like to make. Dysphagia generally needs evaluation, and iron deficiency also needs evaluation. We'll talk about iron deficiency at the end of the talk. Now, dysphagia, which I'm going to refer to, is transfer dysphagia, which occurs right up the gastrointestinal tract, where there's difficulty in transferring food from the mouth to the upper esophagus. If you have dysphagia lower down in the esophageal area or esophageal dysphagia, that definitely needs evaluation because you might be dealing with a tumor or a stricture. We are not talking about that today. When there is difficulty in transferring, it's not a simple answer because it's a complex problem, just like anorexia. It involves a lot of muscles. It involves the nervous system, central and peripheral, and it involves the muscles of the oropharynx and larynx. And the disorder is not that easy to reverse. For example, Parkinson's disease, stroke, you've already had the stroke, or dementia. Bad news. So what can you do? What is the consequence? The consequence is coughing, often while you eat. You simply ask the patient, are you coughing while you eat? Aspiration and pneumonia and poor quality of life. So people come to us with dysphagia, and as I'm going to illustrate in the next few slides, it's a common problem, oropharyngeal dysphagia. So this is a slide that refers to the consistencies of foods. This is from the International Dysphagia Diet Standardization Program. And you can look at drinks which are water thin. This is water, thinnest. And you can look at regular food that we all eat, which is the thickest. So there are grades from 0 to 7. And in patients with oropharyngeal dysphagia, you might be interested in choosing food that is somewhere around here. And that is what the nutritionists do. If I am to describe what does that food feel like, it's like honey or nectar in terms of consistency. This is easier to swallow. You can change a liquid such as a juice, which is slightly thick, or a glass of coffee by adding what is known as a thickener and changing the consistency, because this is more likely to be swallowed with ease rather than very thin, and these very thick are equally difficult. My own mom in the nursing home recently, she has Alzheimer's, she's in her 90s. She has had it for over 5 to 6 years. She takes a lot of time. She was evaluated by the nutritionist with these different foods, and she came up with a plan that she's still good for soft and bite size. You don't have to change the meal. So these nutritionists try different consistencies, and then you have the head up position, not the lying position, chin down, and that's how you eat. So before I say that that's what you should approach, this is the key statement, a very important statement. Do not offer PEGs to patients with advanced dementia. Instead, offer oral assisted feeds, otherwise known as comfort feeds. All of our perceptions regarding PEGs, we do a lot of PEGs, including our hospital, and I'm always anti-PEG because PEGs do not change your life expectancy, do not improve your quality of life. By the way, do not decrease aspiration. It's actually more common, and they do not prevent your pressure ulcers. So the longevity following a PEG in advanced dementia, which is when you place a PEG, is often months or less than a year to year and a half. So most patients end up dying. I'm not saying everybody does. The exceptions, less than 10 to 15% of patients will go beyond 2 years. So a lot of our perceptions are wrong. The reality evidence proven is otherwise. So when you get a patient with PEG, who is indicated for PEG, I'm not saying I get the patient with PEG, but once in a while the nursing home literally sends the patient for placement of PEGs. So is that correct? First of all, determine the patient's capacity. Is the capacity present at this time? And you're likely going to find out no, because this is advanced dementia. And before you go to the caregiver's opinion, find out what this patient had wanted in the past. Is there an advance directive? What did this patient tell you in the past? Did she actually want everything to be done to keep her alive to the very end? After that, as the caregiver, what would you do? And before you say what you would do, is that what the patient wanted? It's what the patient wanted. If all this is a conflict and you find that you don't go anywhere, you might use a multidisciplinary approach. But before that, find out whether there are any reversible factors. There are often reversible factors, as I'm going to demonstrate. If there are reversible factors, that is great. If the patient's caregiver asks what else can be done, your answer would be to suggest comfort feeding. And if you are going to agree for the PEG, which you are forced to do sometimes because of the caregiver's strong beliefs, you are not going to, the word used, do not give undue favorable prognostic answers. That the patient is going to do great, will not aspirate. That's exactly the opposite. You should bring out the negatives. You agree to give the patient the benefit of the doubt and place the PEG, but don't promise wonders. Now, on the other hand, if you have a stroke, you could place a PEG on a temporary basis if you think that the life expectancy is beyond 4 weeks. That's allowed, and the PEG comes out. If there's advanced cancer where there's a swallowing problem in the gastrointestinal tract, rather than a PEG, you would be placing a gastrostomy, and that's not an ethical problem. So this has some ethical considerations, and you should resort to comfort feeds, which means sitting the patient up, feeding slowly and with time, and with what we call as therapeutic touch or tender loving care. Why is this not being done? And that's what is happening now to my mom. We have actually employed people to sit with her. We pay for this so that they can feed her for all her meals, and she's eating fine. And with this advanced dementia that she has, we have determined that we are not going to put in a PEG at the very end of her life. Now, this is sometimes colloquially referred to as pleasure feeds. The correct term is comfort feeding. So this is a case where there was difficulty in feeding, and this patient got an endoscopy to look for any obstruction. And lo and behold, this is what we found in the pathology. They actually put in a gastrostomy before the results came out, sadly, because she had lost 30 or 40 pounds. But this indicates they were all medications or crystals in the pathology specimen. This was pill esophagitis. The pills had blocked the lower esophagus, which was ulcerated. The endoscopic findings suggested that the ulcer might be cancerous, but it was not. And the good story is in about 3 months, all that healed. And she started eating. She had the gastrostomy, and she started putting on weight, and she said, I can eat normally. And the gastrostomy came out. This was actually one of our cases. A second story where a patient loses weight, comes into our facility, and the nursing home had asked for a PEG. This person had lost 30 or 40 pounds, had a language barrier. After a lot of trouble, we got this patient to speak in his own language. And with difficulty, we found out his memory and cognition was perfectly intact. He could name all the previous presidents, which I could not do. So what was wrong with him? Well, in further evaluation, this guy had Parkinson's disease. So the neurologist came in and evaluated him. He could not eat. He was weak. He had lost weight. We got him to take medications, essentially levodopa, carbidopa. The guy improved dramatically, went back to the nursing home without a PEG, and in 3 months gained most of the weight that he lost. He was eating like a pig.